we had a prior trial that used a similar strategy with post-transplant cyclophosphamide and transplants for hematological malignancies using mismatched unrelated donors, so matched at 7 of 8 down to 4 of 8, using bone marrow. And bone marrow was used in that initial trial because bone marrow has been shown to be associated with less risk of moderate to severe chronic GVHD post-transplant. So we wanted to mitigate the risks as much as possible in that initial trial. At the time but that only accounts for about 15% of the grafts that we provide for adults. So we wanted to carry this forward and see if we could see similar results using peripheral blood stem cell grafts, which are much more commonly used. So about 85% of patients currently receive in the adult setting, currently receive peripheral blood stem cell grafts. And so we took that forward in the ACCESS trial, and we are seeing similar, if not better, results using peripheral blood stem cells in the ACCESS trial now. So in the original 15 MMUD trial that used bone marrow, out to 1 year post-transplant, we saw 1 year overall survival of about 79%. In the myeloablative conditioning arm of the ACCESS trial using peripheral blood stem cell grafts, we're seeing an overall survival at 1 year of 84% with low complication rates. So severe acute GVHD at only 8%, and moderate to severe chronic GVHD at only 10%. Now, 8 and 10% still impact a large percentage of the population, but that's much better than what we see with traditional approaches. So now we've really expanded the potential to use mismatched unrelated donors across the spectrum of graft sources that are used in the adult donor setting. We did see grade 2 to 4 acute GVHD was seen in about 30% of the patients. Only 8% of those went on to develop grades 3 to 4 GVHD. And in most cases, and this is more anecdotal than what was seen on the trial, is that the acute GVHD that develops after use of post-transplant cyclophosphamide tends to respond quite well to first-line therapy, which is systemic steroids, as opposed to having to revert to second or third-line therapies to address the symptoms. So that's good news. It's a bit more manageable potentially of an acute GVHD, and that appears to be translating into lower rates of chronic GVHD as well, at just 10%, as was seen on the myeloablative conditioning arm of the ACCESS trial, which is really great news for patients and frankly for the clinical system as well. Less patients that are going to GVHD clinics is a great thing. It's important. It's fantastic for quality of life for those patients, but then also decreases the burden on the healthcare system as well. So trading one potentially lethal disease for a chronic disease isn't maybe a reasonable trade-off for many people, but the more that we can eliminate that entirely for patients receiving these therapies, the better. And so an ounce of prevention is worth a pound of cure at the end of the day. And so the more that we can do to prevent GVHD, the better. And so we'll be exploring that further in future studies. Not every patient has an available matched donor within their family. Family size have been shrinking in the U.S. for many years, and with that comes a lower likelihood of having a fully matched sibling donor, which would be the gold standard donor for allogeneic transplantation. In the event of not having a fully matched family member, turning to the registries is a great way to identify a donor. A matched unrelated donor does lend the best chance of an outcome for patients in need of transplant in the past. That's what we have seen. But that's not available for all patients in need. So there's a range. So in the ethnically diverse population, it ranges from 29% to about 60% would have a fully matched donor on the registry, in comparison to a non-Hispanic white, which would have about a 79% chance of having a fully matched donor on the registry. When we're able to use mismatched donors, so to go down from an 8 of 8 to a 7 of 8, a 6 of 8, or a 5 of 8 matched donor, or even down to a 4 of 8 matched donor, which we have performed on the ACCESS trial with quite a bit of success, you really expand the donor pool to all patients in need. So at the 7 of 8 level, that takes the group that had a 29% chance of finding a donor up to 84%. So an incredible increase in the availability of donors, and going to a 6 of 8 match, that goes up to 99%, 5 of 8, essentially 99.9% of all patients would find a donor on the registry, which is really important. So that just eliminates the donor access barrier, which is critical. Donor availability is no longer an issue, so it should not be a barrier to transplant. There's other barriers to transplant that we need to consider, and so that is something that we've been evaluating through the ACCESS trial and looking at the socioeconomic status, social vulnerability of the patients that we are serving through this trial, and we have shown that they are a more vulnerable population and need more support services. So something to pass on to the nursing and APP teams is to be able to support those patients, understand those needs that they have, and recognize that and help them navigate the system. And that can be reaching out to the NMDP, the ability to participate in these trials that we have open at centers across the country, and many centers, like, for example, Dr. Al-Malki, who will be presenting the results of the ACCESS trial, is at City of Hope, which is based in Duarte, California, an extremely diverse patient population there, and they are able to serve that patient base using a mismatched unrelated donor transplant strategy and turning essentially no patients away for lack of a donor with availability of these approaches. So that's great news. And also for the nursing and APPs, that the complication rates appear to be lower within the post-transplant cyclophosphamide-based GVHD transplant setting. So lower rates of acute and chronic GVHD, which is great news for quality of life for those patients, but also burden on the healthcare system and the need to be able to support those patients with their new chronic disease that they may have developed after their transplant. If we can continue to reduce those rates, that'll be critical.